We need to do better. We certainly recognize that, and we need to realize that not every person is the same.
Turning 40 means many things. We've reached middle age. Teenagers now refer to us as old. And we begin this annual visit to get our mammograms. We preach this at Komen because we know that regular screening saves lives. The earlier it's detected, the better chance a woman has to live a long, full life and really enjoy that whole back half. I'm Suzanne Stone, and this is the More Than Pink podcast. So there's more out there than just the mammogram to accomplish this screening. Dr. Elizabeth Morris is a Komen scholar. She's also the chief radiologist at Memorial Sloan Kettering Cancer Center, where she leads a team pioneering high-risk screening that includes MRI, digital mammography, 3D ultrasound, and a lot more. And what they're learning could be game-changing. So mammography has been the gold standard of finding breast cancer for decades. What is it? When we go for these appointments, what are we doing?
So mammography has been the gold standard for decades, and that is perhaps one of the problems that we face because in reality it hasn't really changed that much. And what we're looking for are anatomic distortions and sometimes secondary signs of malignancy to point us to an area that could possibly be cancer in the breast. And because of that, that means that we are limited with mammography, particularly in some women who have very dense breasts, where we're unable to see these small masses growing or we're unable to see areas of distortion. And so we're unable to detect cancer in some women at a very early stage. It has to grow to be much bigger. And so I, along with many other people, feel like there has to be a better way to screen women other than just mammography. And we have improvements with mammography over the years, but the basic concept has not really changed because we still only rely on X-rays that go through the breast to try to find breast cancer. And the improvements that have happened have been digital mammography, first of all, and that's helped women, particularly in dense breasts, but it hasn't been the big game changer that we were really hoping for. And the newest improvement on mammography is what's called digital breast tomosynthesis, and some people call that 3D mammography. And that has helped as well. It has helped increase cancer detection. But it also has not been the game changer that we really need. And because we really need to improve detection of very small breast cancers before they have metastasized and moved to other parts of the body, there's been exploration into other areas such as ultrasound, which is now in many states recommended for women who have dense breasts, and also in other more functional-based tests that use an injection and look for increased vascularity of breast cancer lesions. And usually if a breast cancer is 3 millimeters or so, there is some increased vascularity associated with it because it needs blood vessels to grow. So those techniques are really interesting. And it's something that we are very interested in exploring and studying. And the first one that has been around for the longest is breast MRI using gadolinium as the contrast agent. And many, many studies have shown that it is the most sensitive test for picking up breast cancer, particularly in high-risk women. Now, there's a trial that's going on that's looking at more average-risk women and with dense breasts with breast MRI to see whether it also could be used in that population as well. And the preliminary results seem promising from that trial. What happens with the contrast is it goes to very small lesions, and we're able to pick up smaller breast cancers and those cancers that may be more biologically aggressive with this more functional-based imaging using contrast. So the problem, though, with that is that MRI is expensive, it's not available in multiple areas, and access really is a problem for many women. And often insurance won't pay for a breast MRI exam. So that's led other people to investigate lower-cost alternatives such as contrast-enhanced digital mammography, and that's called CEDM or CESM. And the advantage of contrast mammography, it has some of the advantages of breast MRI because you do inject contrast and you are looking at a functional assessment of the breasts, and you're looking for very early breast cancers that have increased vessels associated with them. It is using a different contrast agent than MRI. It uses omnipaque or, a CT contrast agent, the same agent we use for CAT scans. And it's basically given to the patient before a routine mammogram is performed. So it's a very quick exam. It's fairly low cost. It's a little bit more than an average mammogram, but it gives you a much more detailed view of the breast. So there are many studies going on looking at this technology to see whether or not it could potentially help in the detection of breast cancer for women where the mammogram is somewhat limited.
This is a huge field. This is obviously not just my mom's mammogram.
No, not at all. And I think that's where we're headed, is to personalize breast cancer screening per individual. So it's not just a generic, everyone has to get this examination. Because the more we know that some women need more, and there potentially could be other women that need maybe less. And so there's a lot of discussion currently about when a woman should be assessed for breast cancer risk and should be given options for breast cancer screening.
And that is absolutely a topic we hear a lot.
Right.
We get those phone calls at our office all the time.
Do you?
Well, how often am I supposed to? Or I didn't think I had to go back. And it's certainly a topic of conversation.
Right. So the problem is that there's been a lot of confusion with the guidelines that have come out recently, and I'm someone that likes to keep things simple, and I think for what we currently know and for what we currently recommend, yearly mammography starting at the age of 40 is the best way to go. We know that saves the most lives, and it has been shown in multiple trials that lives are saved. The other thing that happens is you pick up cancers at a smaller stage so that you can have less therapy as well.
So you talked a lot about, this idea of personalized screening, which I think for all of us in our, as we're in the middle of middle age, and we're right in that zone, it's an exciting thing, and certainly something more and more people are asking about and curious about. As a woman, though, before you're 40 and you have your first mammogram, how do I even know what I'm supposed to be asking for?
Exactly. And that's where the discussion is, because how do we identify those women who possibly could be at increased risk, who probably would benefit from screening before 40? Because to me, having a woman come in their 30s, sometimes even in their late 20s with a palpable cancer, is heartbreaking, because you feel that possibly you could have picked it up earlier, and maybe the outcome would be better. So the question is, and that's what we're actually having a meeting here in the city, having people come in to talk about this, because it's really on, I think, everyone's mind. is when do we recommend that a woman find out, first of all, what her family risk is. And there are many calculators that can help you with your risk. And it appears there's a lot of different ones out there, but probably the best risk calculator that you can actually get online is called the Tyrer-Cuzick model, and it's abbreviated as IBIS as well. It's been used in that group. So you can go online and actually put in the numbers and find out what your 10-year risk of developing breast cancer is and what your lifetime risk of developing breast cancer. Most experts think that your 10-year risk is probably the risk that you should use for deciding on screening regimens. And but that has to be incorporated into an assessment of, do I need to be screened and do I not need to be screened? So it's a lot more intensive than just saying you need to come for a mammogram every year starting at the age of 40.
It's a lot different than that. And when we talk to young women who are breast cancer survivors, they always say this, one of the women we talk to a lot, her name is Kathleen, and she says, I graduated from college and the next week, instead of looking for a job, I was looking for an oncologist.
Right.
That's not supposed to happen.
That's not supposed to happen, and we don't want that to happen.
So we talk about the breast MRI and, and all of these other modalities that are so different to somebody who hasn't had their first mammogram yet, right? They've never had that joyful experience. When you're looking at them as a radiologist and you're looking at these images, what are you really seeing? How is it really different?
You mean a young woman compared to an old woman?
Sure. Well, if somebody has dense tissue as opposed to not dense tissue, what does it look like?
So dense tissue is a problem for us in radiology. It's sort of a double whammy in a sense, because on the first hand, you have a lot of tissue that's usually just collagen tissue or even epithelial tissue that's in the breast that's masking the cancer, so it makes it more difficult to find. So it sort of masks the cancer, and you can't really see it very well on the mammogram. So that's the first issue. The second issue is that women with dense breasts have a little bit increased risk, actually, of developing breast cancer. So we're not doing very well with mammography with density because these are the women who are at increased risk and really need to be screened carefully and have their cancers picked up early. And it's been shown that women with dense breasts have more interval cancers, and the type of cancers they have are potentially more aggressive. So that's why there's been so many laws in many states that have been passed. They're called the breast density laws that require radiologists to notify the patients and tell them that they have dense breasts and that there is a limitation of the examination, and perhaps they might want to consider doing another test like MRI or ultrasound.
So I know that what I'll hear from this is the comment that my insurance doesn't pay for that.
I know.
What a challenge.
And that's not right. And so many of these laws, and that's why it's controversial, because in some states the laws mandate that insurance covers it, but in others it does not. And so that falls to the patient. So it's not fair. You're absolutely right.
When we go back, I'd like to go back to this idea of this risk calculator, because I think it's really interesting, and people love to Google.
Right.
For better or worse, we're addicted to just plugging in a question in that search bar and hoping for the answer. So this risk calculator that you're talking about, what are the kind of things that are taken into consideration?
So they want to know your age, usually your weight and your height, to do sort of a BMI type of calculation. They want to know what time you started your period, at what age, because exposure to estrogens is associated with an increased risk. So if you start your period at an earlier age than later, that is going to increase your risk slightly. They also want to know at what age were you when you had your first child. And if you have delayed childbirth, that does increase your risk as well. They also have questions about whether you've ever had a breast biopsy, because if you have had breast biopsies in the past, you're at increased risk. Then there are questions about whether or not you are on hormone replacement therapy or whether you've actually ever had hormone replacement therapy, because there are data from the WHI study that show that women who take estrogen plus progestin around menopause are at slight increased risk of developing breast cancer. So those are the kind of questions that are asked.
So if I put in all my information and it comes back and tells me I'm at high risk, how does my screening regimen look different than somebody who put in their information and it said low risk?
So your screening depends on what the risk calculation came out to be. If you have a cumulative lifetime risk of 20% or more, you would be eligible for MRI screening every year. And most insurers do pay for that at this point. So you would be getting a mammogram and an MRI every year. If you turn out to be at elevated risk, sort of what we call a moderate increased risk, and you don't reach that 20% threshold, then insurance won't cover for that. And usually most women at that point will have a screening breast ultrasound. That's usually our default test if they don't qualify for MR. But it should be recognized that ultrasound is not a replacement test to MR. There's been very many studies that have shown that ultrasound misses a lot of cancers that MR picks up.
So screening is a lot more complicated.
It's very complicated. And I think, I think it's important to keep it simple. I mean, we have the recommendations yearly after 40, but I think in the next 5 to 10 years, we're going to be seeing a lot of permutations on that. Part of what needs to be figured out is who owns this area, like who actually takes on this assessment. Is it the primary care physicians, or is it the radiologists, or some other physician? I personally think it needs to be the radiologist that takes it on, because they know most about the different types of screening methods that are available and the pros and cons of each one. And so I think we need to take more ownership of this and not put it on the primary care physicians who are overburdened as it is.
Speaking of a primary care physician, a lot of the women, obviously, that Komen is helping out probably don't have access to something like an MRI. Right.
So that's where I think the contrast mammo is really a powerful tool. It's much lower cost. It's only a little bit more than a regular mammogram, and for most insurers, they are covering that test. It gives a much better look at the breast in a functional way, and so I think for an option going forward for access, it's probably going to be a better test. But obviously, these are early days with this technology, and it's only been around for several years. We need to do the studies to make sure that we are going to be finding an increased number of breast cancers. So hopefully those can be done in the next couple of years, so this can be offered more around the country.
It sounds like if I get the opportunity and we get to talk again in 5 years, this might be a whole different discussion.
Whole different discussion. I think it will be. I mean, we haven't even talked about looking at your genetic information. Like there are multiple companies now that are able to swab your cheek and look at your cells from the cheek and look to see whether or not you have genetic mutations that increase your risk for breast cancer, or you have a profile that is associated with an increased risk. So that may even factor into the future. So the assessment, I would imagine probably in your mid-30s or so, where you would go in, you would have your genetic information looked at, you would find out if you're dense or not on mammography, and you would have a careful risk evaluation done, and that would come out with a screening algorithm that would be personalized to you.
Completely different from our current annual exam.
Yeah.
No genetic testing happening now.
Yeah, and more interesting research in the future. Who knows? In maybe 10 years, we won't even be doing any screening with mammography at all. There's a lot of interest in looking at circulating tumor DNA in the blood, and so there are many companies who are looking at seeing whether they are able to detect these incredibly small, infinitesimally small circulating tumor DNA markers to show that you have a cancer developing. So it's possible that we will be having a blood test in the future to identify whether or not we have any abnormality in our blood, and then if that comes up with something abnormal, then we might be doing some imaging to find out, is there anything there or not.
Really exciting stuff coming out, not just from Memorial Sloan Kettering and from you, but from everywhere.
Everywhere, yeah. No, but I think there's a real groundswell of feeling that we need to do better. We certainly recognize that, and we need to realize that not every person is the same.
We are all different. That is the truth.
Different.
The biggest risk factors for breast cancer are being a woman and getting older. Two things that most of us celebrate every day. And it's the uniqueness that is you that makes life so exciting. And when it comes to screening for breast cancer, very challenging. It's exciting to think that one day each of us may have our own personalized cancer-fighting prescription. I'd like to thank iHeartMedia for making this podcast happen, Mike for turning the microphones on, and the whole Komen Austin team for helping me prepare for today's episode. Susan G. Komen Austin is an affiliate of the Susan G. Komen Breast Cancer Foundation. If you need resources, information, or have a comment about this or any of our episodes, just reach out to us at podcast@KomenAustin.org. Thanks for joining us today. We'll talk to you next time. And please, always, be more than pink.